How's it going, guys? So, exceedingly high yield question for hematology for step 1 as well as pediatrics for 2CK. I will cut to the fucking chase, tell you exactly what you need to know to increase your score, sans all of the superfluous horseshit, okay? So, before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. And find me on Instagram, Mehlman_medical, MEHL_medical. Link is down below. Also, find me on Telegram. Links are down below. Now, hopping into the actual fucking question here, where we have this 4-year-old boy. He's in for a well child examination. He's active, healthy, no past medical history. Physical exam shows no abnormalities. His diet consists of vegetables, fish, and chicken, no red meat. Hemoglobin is low at 10.1 grams per deciliter. Normal range for males and non-menstruating women is 13 to 17.5. For menstruating women, it's 12 to 17.5. MCV is low at 66. Normal range is 80 to 100. So he has a microcytic anemia here. White blood cells are normal at 7,000. Normal range is 4 to 11,000. Platelets are 250,000. This is normal. The normal range is 150 to 450,000. So red cell distribution width. This is the start of where some students say, what the fuck, okay? As I said, I will tell you exactly what you need to know for the USMLE. If red cell distribution width high, answer iron deficiency anemia on USMLE. So as we can see, choice E, iron deficiency anemia, wrong fucking answer, okay? So red cell distribution width will be normal or low for hereditary spherocytosis as well as thalassemias on USMLE. It's what I've observed on NBME exams, okay? And a brief explanation is, if I'm improvising, it's likely that when we have iron deficiency anemia, there is a non-uniformity in the sizes of the RBCs that are released from the bone marrow. You're going to have some that are small, microcytes. You'll have some that are normal. So the distribution width of those sizes is expanded. Whereas for thalassemia, where we have a mutation in the alpha or beta chain, decreased ability to synthesize the hemoglobin, we have more of a uniform microcytosis, okay? So therefore, decreased distribution width. Moving on, hemoglobin electrophoresis, no abnormalities, also very important detail. So normal adult hemoglobin is alpha 2 beta 2, that's HbA or HbA1. In contrast, HbA2 is known as, or I should say is alpha 2 delta 2. That is increased in beta thalassemia, okay? So hemoglobin electrophoresis, if they tell you increased HbA2 and HbF, both of those, beta thalassemia is what you need to know for USMLE. Very fucking important. Alpha thalassemia, in contrast, for minima and minor, if you have 1 or 2 mutations, you have a normal hemoglobin electrophoresis. Okay, if you have 3 mutations, you get HBH, which is a beta 4 tetramer. If you have 4 mutations, it would be a gamma 4 tetramer, which is hemoglobin Bart's. Okay. Direct antiglobulin test is the same thing as a Coombs test. It just means you have antibodies against your RBCs. It's negative in this case. So we can eliminate hemolytic anemia because we don't have antibodies against RBCs, okay? If you have like a drug or infection, and then we have high indirect bilirubin, unconjugated bilirubin with positive Coombs test, I mean, that's your hemolytic anemia, classic, right? So just walking through the answer choices here, although I've already explained a bit. Alpha thalassemia, this is our correct answer because we have no abnormalities on the hemoglobin electrophoresis in the setting of an RDW that is not elevated, so we eliminated iron deficiency anemia, and we have microcytic anemia. Okay, I mean this is classic for alpha thalassemia. Beta thalassemia, as I just fucking said, would give you an increased HbA2 and HbF on hemoglobin electrophoresis. Glucose 6-phosphate dehydrogenase deficiency, I mean, obviously very high yield diagnosis overall for USMLE, but we would get some sort of presentation as far as an infection or drug that precipitates hemolysis. They might give you a boy who's jaundiced or has increased unconjugated bilirubin. They like giving you bite cells with Heinz bodies, those types of things, okay? So G6PD deficiency, wrong fucking answer. Hemolytic anemia, as I just said, we have a negative Coombs test, so it's wrong, and IDA is wrong because we have the low rather than high RDW. So lots of high yield concepts here for hematology for step 1 as well as pediatrics for 2CK. As I said, I'm not going to make this an extended clip, okay? Cut to the chase here. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. and I appreciate your time. That's it.